Hi, this is Andy Kaytes, and we're here at CROI in Seattle, 2015. Joining me, to my immediate right, Dr. David Wohl from University of North Carolina. We've got Kathleen Squires from Jefferson University in Philadelphia, and then Dr. Dan Kuritzkes from Brigham and Women's Hospital in fine, snowy Boston. So today we're going to talk about the future of antiretroviral therapy in prevention of HIV. And that almost sounds like a contradictory term in a way, because how do you prevent something if you're already taking antiretroviral medication, and you'd only be taking antiretroviral medication if you had HIV? So what is all this about prevention?
You know, I think Rafi Mendowitz framed the issue very nicely when he gave his plenary talk, and it's think about this as malaria prophylaxis, right? We use the same drugs that we use to treat malaria, to prevent malaria in people who are going to travel to an area that has a high risk of acquiring malaria. And here the concept is to use some of the same drugs that we use to treat HIV for people who are at high risk for acquiring HIV to prevent them from getting it, so then we don't have to deal with HIV and all of its complications, which are many more than just the need to take antiretroviral therapy.
So there's, 24 plus HIV medications on the market, approaching 36. Does that mean you could take any of them for prevention?
Well, what we know is that some of them have been studied, specifically drugs that are in what are called the NRTI class, or reverse transcriptase inhibitor class, nucleoside analogs, and a drug called tenofovir, or a combination of tenofovir and emtricitabine, have been studied for this indication. And there have been a number of studies now that have been performed in men, in groups of patients men who have sex with men, so-called MSM, in heterosexual couples, and in IV drug users. And studies to date have indicated across those groups that the use of these drugs, either the single drug alone, but in most cases the combination of the two nucleoside analogs, have been effective in preventing transmission of HIV infection. What has been very interesting in the studies is that the rate of protection has been very closely allied to adherence, which makes sense. If you don't take a medication, it's not going to work for you. But in people who have taken the medication, the rates of protection have been very high.
So that's the pill Truvada, isn't it?
Correct.
Nice other blue pill, I guess.
Right.
Right.
Although the two may be used at the same time, who knows? Who knows? Well, okay, that's great. So we're talking about the future, and in the future, maybe one size fits all isn't going to work, and if we just have that one pill, maybe women won't like it as well as something else. Maybe it doesn't work as well for someone's lifestyle. What else is out there? What's on the horizon?
Well, I think we like choices, we like options. Although when you get too many choices, then we see paralysis. But I do think that we can have more than one choice. And while Truvada works really, really well for people who take it, and we're learning, there might be patterns of adherence that are acceptable, that you may not have to take it every day. Right now it looks like you do have to take it every day, but there's a lot of research going on to understand, can we take it more strategically? And some of that's was talked about at this conference. That's evolving. But you can imagine that there are people who wouldn't want to take a pill or two. And there are other techniques and modalities that can be used, such as an injection. When people want to take an injection, let's say every 3 months or so, that would offer the same kind of protection.
Just once every 3 months?
Possibly. And I think that's something that's exciting and is being studied right this moment. What about a gel? People have been talking about gels for a while, or a ring that could be inserted in the vagina for women who can get then protection from a drug that's eluting out from a ring. So there's all these technologies that I think could be brought to bear to make PrEP even better.
Got it. Well, and isn't there a difference in the levels of tenofovir that exist in the vaginal tissue as compared to the rectal tissue?
So there's a difference depending on where we're trying to protect, obviously, in terms of transmission is across the genital tissues. And so the amount of drug that you can get into the genital tract differs depending on whether you're taking it orally or it's actually inserted in the case of a gel. And then there is a difference in terms of the levels of drug that can be achieved in the vaginal tissues in the vagina as opposed to the rectum. And there have been studies very carefully looking at those differences. So that may affect whether oral or topical use is better, and depending on which orifice is being used. So that will help tailor future research efforts too.
Interesting. And there's a new formulation of tenofovir that's kind of on the horizon as well. There's a TDF and a TAF or TAF. What would those be?
Yeah, so I think that's an interesting question. So TAF is both TDF and TAF are prodrugs of tenofovir, which is the active drug, and they're used because it helps absorption of the drug when it's administered orally. You can give much smaller amounts, 1/30th the dose of TAF in some formulations is needed compared to the dose of TDF, which is in Truvada. The studies presented this afternoon on the fixed dose combinations of these drugs for treatment of HIV showed that the TAF formulation is as effective and as well tolerated as the TDF formulation. There will be some data presented tomorrow suggesting there are some possible improvements in the effects on bone and kidney function, although the clinical significance is less certain. What's not known today is whether TAF will be developed for prevention, because it would be nearly impossible to do a study that compared TAF with TDF for prevention. It would be an enormously large study to show that it was as effective, and whether the regulatory agencies will accept bioequivalence, showing that you get the same level of drug, because blood levels is not the point. You actually get lower blood levels with TAF, but higher cell levels, but that's in peripheral and lymphocytes. What about in the genital tissues that Kaytes was just talking about? So there's not a clear path, an easy path, by which TAF can be brought in to substitute for TDF for PrEP.
There's a challenge there, I think, for any new PrEP, and that is we already have Truvada now, and it is really effective. So you now have to compare it to something that works already, and so you do talk about large studies. So how do you bring in a new pre-exposure prophylaxis when you already have something that works really well? I think what the company will do is animal studies first, and the animal studies will be very helpful in understanding some of the protection that can be offered. And some of those can be very, very important and influential, because if they're a home run, they really are a green light that we should maybe have some tolerance for this drug and allowance for it. But I do think that there's a challenge, a high bar set for any new preventative measure, because you can't compare it to nothing.
Right. So TAF might be something very appealing to someone who's already HIV positive and is taking their medications and may have some concerns about their kidney function, their renal health, or their bone health. So from that standpoint, if it helped them to be adherent and take their medication and keep their viral load suppressed, then that would also lower the community viral load, yes?
Absolutely.
Yeah, no, any advance in HIV therapy helps everyone. But TAF is important even for people for pre-exposure prophylaxis. If you're going to be taking this drug for months or even a year or two, as many people I think will, you don't want your bone mineral density to drop. You don't want to have renal issues, even though you're HIV negative. So positive, negative, I think the limitations of tenofovir are operative in both cases.
What other drugs beyond tenofovir, TAF, would be on the horizon for prevention?
Well, there's another drug which is called dapivirine, which is in a different class of the non-nucleoside reverse transcriptase inhibitors, which is actually in phase 3 trials right now, contained in a vaginal ring. So this is a drug that's specifically being looked at as a modality for prevention for women. And we're not going to know the results of that for about a year, but there's great hope that the use of that drug, plus other drugs that are being looked at, to be instilled into a ring would be an advance specifically for women, so that they can use this ring and insert it episodically. So that drug, and there's drugs in yet other classes that are being looked at, and some of these drugs are very long acting. So then that brings up, as David mentioned, the depot formulations that you could give a shot, up to every 3 months. Or a depot formulation such as we use for contraceptives. Women use depot forms for contraception where they can have something inserted, every several months. So it's
Would there be a possibility of drug-drug interactions with that? Because it seems that hormonal contraceptives clash a little here and there.
correct.
Well, it'll depend a lot on the drug and on what's being used. So in the case of the vaginal rings, there probably wouldn't be a lot of concern because you're really delivering both drugs locally. And for the hormonal contraceptive rings, you just need tiny amounts of drug to get into the blood to suppress ovulation. With oral dosing, it could get a bit more complicated, but at least at the present time, the drugs that are being considered for long-acting formulations are drugs that have relatively simple metabolism and don't interact much with other drugs.
That's great. It sounds like more choices, which is for some a really good thing, especially for women. So where do you think something like implants or pumps like they have for diabetes or patches or anything?
You're not going to need it. So what's amazing about what we've learned about long-acting drugs, which are not going to be the be-all and end-all for treatment of HIV. It's going to help some people, and I think it's exciting. But it's remarkably easy. They take drugs like rilpivirine, which is what we just mentioned, and also a drug that's a lot like Tivicay, like dolutegravir. They put this into a big canister with steel balls, and they spin the hell out of it, and they get little pulverized drug. They put it into a solution, and you inject that into your butt. And it sticks around for a really long time, such that you could imagine taking that shot every 2 to 3 months, and it working like PrEP, working like taking Truvada every day. I think there are going to be people who are going to be very excited about that. Again, it's not going to be millions of people, but it'll be thousands of people who will say, you know what, I'm okay with getting a shot every 3 months and going to my doctor, and not having to worry about taking a pill or did I not take a pill. There'll be HIV positive people who'll be really into this, but I also think there's a role for it in PrEP. And the HPTN, which is the HIV Prevention Trials Network, is engaging in studies right now to look at acceptability and tolerability of doing exactly that.
Wow.
I think the other thing we want to remember is that for the vast majority of people who are at risk for HIV infection, they live in resource-poor settings. So we want to have technologies that are easy to administer and cheap to administer. So while technology is a wonderful thing, in many parts of the world, we just can't afford it. So we want to make sure that we can deliver these drugs in ways that are acceptable and don't require a lot of money and a lot of technology.
So it would have to be scalable for one. It would have to be able to be rolled out to all parts of the world. It seems to me like there would be some situations where stigma comes into play here, where women who maybe don't have the best home life and are in situations where they can't control the pills they take or whether or not they are going to have sex that evening. Trying to dance around that a little bit, but it seems like an injection could be a pretty nice answer to all of that. And
I think both the long-acting injectables and the vaginal rings are really good solutions to some of those issues.
Yeah, I think the other issue is who's going to deliver this in terms of kind of rolling this out. And really, it makes the most sense that this modality will be incorporated into primary care settings in the sense that you go to your doctor for other things like getting vaccinations and so forth. So it's part of a prevention scheme for an individual depending on what their risk is. And that is something that Dr. Lanovitz talked about and described in his plenary. And it's an issue, for instance, in the United States because up to the present time, many primary care providers have been very uneasy about delivering PrEP because they're not used to the medications. They've heard about the side effects. They really don't know how to monitor patients. But for those of us who do HIV, and I think, well, I can't speak for my fellow panelists here, but I administer PrEP, but I don't have a lot of extra time in my schedule to do that, but there are a lot of people who could potentially benefit from it, and it needs to be a modality that gets moved out into mainstream medicine.
Yeah, it's a big problem. I think the problem is not only do the primary care docs, who do a great job, obviously we all have primary care docs, not only do they not think about PrEP very much, but they don't think about sex very much. And I think that's the biggest hurdle right now, is we really need to have a huge push to get docs to start talking about sex, asking people about sex routinely during their visits. You see a person once a year, it's a perfect opportunity to say, let's talk about your love life. Tell me about what's going on. And not making assumptions. And even HIV doctors don't do a great job of this. And when we learn how to do it, we learn a lot about our patients. So I really am a big advocate for more sex education among clinicians.
So there's 3 doctors at the table. Have any of you ever met a doctor that has spare time?
No, unfortunately not.
So that seems to be a problem. You know, the CDC has guidelines that people should get HIV tests,
Right.
and that should be part of a normal health screening.
Right.
Doctors, primary care physicians aren't talking to their people about that. They don't want to take the time in some cases to have a conversation about it.
Sure.
If they're not willing to test somebody for HIV, how willing will they be, or what's the magic button to make them willing to talk about PrEP? Or is the answer maybe having their assistants, the medical assistants, talk about it?
I think there is a magic button, but it's the same magic button that solves all the other primary care problems, and that's money. You have to pay people to take care of their patients.
Mm-hmm.
And the reason there's no time in the day is because people are seeing so many patients because they get so little per patient. And we need to make preventive care a reimbursable and a significant component of the primary care visit, and pay people for talking to their patients as much as we pay people for sticking needles and instruments into their patients.
I absolutely agree with that. I agree with David too. I think we've not done a very good job about including sex as part of, what I call the ABCs of medicine, and people are squeamish about talking about it. It's fine to ask about high blood pressure and what you eat and so on and so forth. People are much less, and physicians specifically, much less used to talking about sex, and you have to be able to do that to find out if your patients are at risk. So.
Yeah.
There's plenty. I believe there's opportunities, and it doesn't take too long. And really, we integrate it into our practice. We have a lot to talk about with our patients: smoking cessation, diet. We do a lot of primary care as well. And I don't have only 8 minutes. I think that's just criminal. But it doesn't take long to say, "Tell me about your love life. Tell me about what's been going on. Have you been with it?" And just whatever technique you use, but it can be very helpful. It takes a few minutes. And so that visit, you didn't talk about seatbelts. Next visit, you talk about seatbelts.
Excellent, I like it. Well, on that, I guess I'll throw challenges out to the 3 of you, that when you're at the wine and cheese parties or the university rah-rah sessions or what have you, and you see that family practitioner that doesn't talk about these things, maybe get in their ear a little for the rest of the world and just say, hey, talk to your people about this, and don't be hesitant about writing prescriptions for PrEP. So anyway, on that note, I thank you all for your time, and keep on doctoring and keep on researching and keep on doing the good work.
Thank you.
Thanks
very
very
much.
much. Thanks.